St. John's wort sits on a supplement shelf, but people talk about it like a mild antidepressant. Is the honest version that it works, or that the label makes it look more proven than it is?
The honest version is it is one of the better studied herbal products for unipolar depression, especially mild to moderate symptoms, but it is not a generic happiness plant. The WFSBP and CANMAT task force gave St. John's wort strong support for unipolar depression among phytoceuticals, while also stressing quality and standardization as limits. So the evidence signal is real, but it attaches to tested preparations, not every capsule with a flower on the label. The body ladder starts in the gut, not the flower. You swallow an extract, its compounds are absorbed, the liver metabolizes and responds to them. And downstream, the nervous system sees a mixture that can influence mood-related signaling. Trials measure symptoms, not a clean single biomarker. That matters because St. John's wort is a chemical orchestra, and different orchestras can play noticeably different music.
When studies say St. John's wort, are they talking about tea, dried herb powder, or a standardized extract? Because that seems like the difference between drinking coffee and measuring caffeine.
Exactly. Most antidepressant evidence is not about sprinkling the plant into a smoothie. It is about oral preparations with defined manufacturing, often standardized around marker compounds. Those markers are imperfect, but they help researchers avoid comparing a weak batch with a potent batch. The practical takeaway is boring and important. If someone cannot identify the exact product, dose, and standardization, they cannot really borrow the trial result.
What should a realistic benefit feel like? Are we talking about a dramatic lift in a week, or a gradual symptom score change that might matter but is easy to oversell?
Think clinical, not cinematic. Trials usually ask whether people cross thresholds on depression scales or remit, not whether every sad day disappears. In a 2025 review focused on milder depression, 2 St. John's wort trials compared it with fluoxetine and found no significant difference in response or dropout rates. That does not prove it beats placebo in mild depression. It says in those trials, it looked broadly comparable to one SSRI comparator. But this is where people can get hurt. Comparable in a narrow trial is not permission to stop an antidepressant and swap in an herb. Depression relapse, withdrawal symptoms, bipolar misdiagnosis, suicidality, pregnancy, and medication interactions all change the risk calculation. For moderate, severe, recurrent, or complicated depression, this belongs inside a clinician-guided plan, not a private experiment.
So, who is the person where this is even a reasonable conversation? Someone with mild symptoms, no medicines, and good follow-up, rather than someone trying to treat a crisis alone?
Yes, baseline matters because mild depression is not one clean condition. The 2025 Mild Depression Review points out that definitions vary across diagnostic criteria and rating scales, and guidelines often prefer psychotherapy first. St. John's wort is most plausible when symptoms are persistent enough to track, not so severe that delay is dangerous, and when there is a clear plan for what counts as improvement.
How would you judge whether it is helping without just asking, did I have a better week? What would you track so placebo, weather, sleep, and life events do not become the whole story?
Use a repeatable symptom tool, even a simple weekly questionnaire, and pair it with function. Getting out of bed, work attendance, social withdrawal, concentration, sleep, and appetite. Decide in advance when you will reassess. If there is no meaningful movement after an adequate trial, or symptoms worsen, the expectation should change from maybe this herb needs more time to I need a different clinical plan. The biggest safety issue is not usually a stomachache. St. John's wort can make the body clear other drugs faster, especially through liver and transporter systems discussed in interaction reviews. That can lower exposure to medicines where small changes matter. Transplant drugs, oral contraceptives, anticoagulants, antivirals, some heart drugs, and many others. If a medication failure would be dangerous, St. John's wort is a serious red flag.
That makes the product question feel even bigger. If one extract has more of the compounds that drive interactions, Could two bottles have different benefit and risk profiles even at the same advertised dose?
Yes, and that is why the word standardized is doing heavy lifting. Researchers want consistent exposure. Clinicians want predictable benefit and predictable interactions. Consumers often get marketing terms instead. The FDA supplement framework is not the same as pre-market drug approval, and NCCIH explicitly warns that products sold online or in stores can differ from study products. So quality is not a footnote. It is part of the intervention.
Give me the hard stop list.
Who should not casually try St. John's Wort, even if the depression claim sounds appealing?
Hard stops include transplant or HIV medications, anticoagulants, oral contraceptives where failure would matter, many psychiatric combinations, pregnancy without medical advice, planned surgery, bipolar symptoms, suicidal thoughts, and severe or psychotic depression. The positive use case is narrower but real. A standardized oral extract, mild to moderate unipolar symptoms, no interacting drugs, informed monitoring, and a plan to escalate care if the curve is flat or falling.